Hello students, today we are going to discuss about a very important topic in fixed partial dentures. The topic is about occlusion. This is a very frequently neglected chapter but a very important clinical chapter which most of us confuse because of the complexity in understanding this from the textbooks. So I have tried to make this more interesting by incorporating a lot of videos so that you can understand it easily uh, and in a better manner. So when we talk about occlusion, we talk about the contact of the teeth, which is the maxillary and mandibular teeth. But usually when we discuss this chapter or the understanding is restricted to contact of the teeth in a static position. But in reality, there are two different terminologies. One is called occlusion, which represents the contact of the teeth in a static position, which means when the teeth are not moving, the contact of the surfaces of the teeth are called occlusion. But when the teeth start moving, just as in function, the contact of the teeth become dynamic, and so this contact of the teeth, when the teeth are rubbing against each other or moving over each other, is called articulation. So we have these two terms, occlusion, which is a static relationship of teeth, and articulation, which is both a dynamic and static relationship of the teeth. So remember, when we talk about any contact of teeth in a movement, we have to refer that as articulation and not as occlusion. Now let us start with the simple concept called centric relation. This has to be understood more in detail. So we have tried to explain this with the help of a few diagrams. So let us first start with the direction in which the muscles act on the TMJ. Starting with the lateral pterygoid pulls the TMJ in a forward direction. So this can be seen from this picture where the lateral pterygoid is pulling the TMJ in a forward direction. Next is the masseter muscle which pulls it in a forward and upward direction. And then we have the temporalis which pulls the TMJ in an upward direction. So the action of these muscles make the TMJ naturally go in a more physiologic position in a forward or a upper and a anterior position. So this position is more of a muscle determined position rather than the position which is determined by the teeth or ligaments. So this is the posterior most position. You can see that when the TMJ goes to the posterior most position, there is compression of the retrodiscal tissue, which is not physiological. Similarly, in the anterior most position, the TMJ or the disc is out of the TMJ, and this is also not a physiologic position. So the most physiologic position is the anterior superior position of the condyle in the temporal fossa. So the centric relation refers to the bone to bone relation, which is the first bone is the condyle and the second bone is the temporal bone. So the condyle must articulate in the anterior superior position so that the muscles are in a very physiologic and a relaxed position. So slowly when the mandible closes, the muscles guide the mandible to close in this physiologic position, and this physiologic position is called as the centric relation. Now we are not concerned about the manner in which the teeth come into contact when we talk about centric relation. So the centric relation is a position which is not dependent on the teeth contact or independent of the teeth contact, and it is purely determined by the muscles which pull the mandible in a upward and forward position. Thus, centric relation can be defined as a maxillomandibular relationship which is independent of tooth contact, in which the condyles are positioned or they articulate in an anterior superior positions against the articular eminence. So this position is restricted to a purely rotatory movement of the mandible, which means pure rotation movement, which is roughly 5 to 6 millimeter of mouth opening, happens in this movement, in this position. And from this position, all other movements can be happening, like your fully opening position or the protrusive position or the lateral movements. This position is very important because it is clinically useful and it is repeatable and recordable. So what is the difference between centric relation and centric occlusion? And let's also delve into the concept of maximal intercuspation. Now we have seen that when the mandible closes slowly, it is closing under the influence of the muscles alone. So this positions the condyle in an anterior and superior position naturally, taking the condyle into a centric relation position. But when we look at the teeth coming into contact in this position, we don't find that all the teeth come into contact in this position. So only a few teeth or sometimes the premolars or the molars come into contact in this position. So what happens during this position? The contact of the teeth when the condyles are in centric relation, this is called as centric occlusion. So this need not coincide with the maximal intercuspation position where all the teeth come into contact at the same time. Okay, so this position is a centric occlusion position which is commonly used for recording or for oral rehabilitation. Now let us see about maximal intercuspation position. So this is a position in which maximum amount of tooth contact happens. So for this to happen, there should be a small slide from the centric position to the maximal intercuspal position. Now let us see how this happens. When the mandible slowly closes, as I told you before, few teeth or one or two teeth in the posterior come into contact in the centric relation. So from this position, there is a small slide which is called as the centric slide, and after the slide, the teeth slightly move forward and then close into the maximal intercuspation position. Usually this slide is very minimal so that people don't notice this happening during the normal functional movements. So this is called as a centric slide, that is the movement of the mandible while in centric relation from the initial occlusal contact to the maximal intercuspal position, and it ranges only from 0.5 to 2 mm. To make this concept very clear, I have included a video of a normal dentate individual who is trying to close. Now you can see that there is some amount of slide happening in the anterior region. When the patient is actually closing, there is a tooth contact in the posterior which is not visible in this video. But after the tooth contact, just notice in the anterior that there is a small slide and then the mandible closes into the maximal intercuspation position. So this is present in almost all individuals, and it's a very subtle or a very minimal movement which goes usually unnoticed. Now let us talk about occlusal interferences, habitual centric and muscle program or engrams. So just like how we saw previously, if the posterior contact or the centric occlusal contacts are very minimal, it goes unnoticed in most of the normal individuals. But in some pathological conditions, this abnormal contact is very huge that there is a very visible or a marked centric slide. So such abnormal contacts are called as occlusal interferences. These occlusal interferences tend to push the mandible into a habitual position, or we call this as a habitual centric, and because of this the muscles get programmed to this habitual closing, and this is called as a muscle memory or a engram. This is how the habitual centric develops. So in such cases, it is a duty of the dentist to deprogram this habitual centric closure to reprogram the muscle into a normal centric closure before we record the centric relation. This can be seen in detail in the class on interocclusal records in fixed partial dentures. So this video shows a patient who has a habitual centric. You can see that there is a anterior hit, then a hit in the posterior, and then the patient is closing in the maximal intercuspal position. This shows that the patient has lost the muscle memory, or the patient has developed a muscle memory to close in a wrong position. So why is centric relation important? As I told you, it is the most physiologic position and can be repeated and recorded, and it is a starting point for all eccentric movements, and it is a position in which the swallowing function and chewing function happen, and pure hinge movements can be recorded and simulated on an articulator, and it is essential to record if a change in vertical dimension is planned, and it is the starting point for programming an articulator. So let us now discuss about occlusal schemes in natural dentition. So basically, the occlusal schemes can be divided into mutual protection, unilateral balance, or bilateral balance. This bilateral balance is not seen in natural dentition. So it is completely seen only in complete dentures, or it is artificial. So we are not going to talk about this. Under mutual protection, we have a subcategory which is called as canine protected occlusion. Basically, all these occlusal schemes are depending about how the disocclusion happens when the teeth are moving. So this is called a dynamic relationship of a teeth, or rather we have to refer this as articulation of teeth. So first let us see what is mutually protected articulation. So this happens when the teeth are in occlusion or the teeth are in protrusion, as you can see in the picture. When the teeth are in protrusion, the anterior teeth prevent the posterior teeth from contacting. So this is called disocclusion. Similarly, when the posterior teeth are contacting, the anterior teeth are out of contact with the help of overjet and overbite. So this type of protection helps the teeth to function without too much of tooth wear or abnormal forces. So this is a video which shows canine protected articulation. A canine protected articulation is a subtype of mutual protection where only the canine teeth comes into contact. So you can see that the patient is trying to move the mandible to the right side and the canine disoccludes the posterior teeth. So this is a mechanism which protects the posterior teeth from harmful forces, and not only the teeth but also your restoration or your prosthesis. So this happens on the working side, and when the patient is moving on to the opposite side, no tooth comes into contact on the non-working side. Next type of occlusal scheme is called group function, where when the patient tries to move, the canine and few of the posterior teeth are in contact on the working side. So this is called group function occlusion, and because there is contact of teeth on one side, this is also called as unilateral balance articulation. So since these are in dynamic movement, we prefer to call this as articulation instead of occlusion. So just to summarize this, mutually protected articulation is a scheme in which the posterior teeth prevent excessive contact of the anterior teeth in maximal intercuspation, and the anterior teeth disengage the posterior teeth in all mandibular excursive movements. The same thing happens only with the help of canine, then it's called canine protected articulation. A group function articulation is which the maxillary and mandibular teeth contact on the working side, but they do not contact on the non-working side. So as a prosthetic goal,